Been a while, Dr. Pearson. Would you just let us know what's going on and what you've been working on? How about
Sure.
that? So let's start there.
Yeah. Well, as you know, I'm the clinical director at the Eye Center for Children's Vision, Learning, and Technology at the University of Washington, Bothell. And we've got a lot of different projects going on there, which I'd love to share with you and kind of go through them all. I'm also in private practice, so I have a optometry practice, but it's unlike a standard optometry practice, which does regular eye exams for eyeglasses or contacts. I'm a specialist in vision therapy and neurooptometric rehabilitation. So I work with children and adults who have functional vision problems rather than just basic acuity problems or sharpness of sight problems. And these functional problems impact children in their learning and education and development. And they impact adults in terms of abilities to work and enjoy life, doing activities of daily living and so forth. And these kind of problems can be due to developmental challenges, or they could be due to acquired problems such as head injuries, concussions, and so forth.
Okay.
So it's much like physical therapy or occupational therapy. I do vision therapy, which is a therapeutic process of rehabilitating or developing the visual skills that are dysfunctional.
Cool. So what kind of projects are you working on right now?
Yeah, so at the Eye Center. So the Eye Center got started several years ago through a group of interested people with interest in functional vision impact with kids in school, and there was a group of activists, you could say, that kind of really spearheaded the change in the state laws to mandate that school children you get checked for near vision dysfunction, not just distance visual acuity, which has been the case since the early 70s. And this same group also approached Professor William Erdley, who's chair at the Computer Science Department at the University of Washington, Bothell, to see if computer science students could help create some technology and applications that would help with these issues. So this started the Children's Vision Research Group, and the Children's Vision Research Group quickly recruited me, because I have a private practice in vision therapy right here in Bellevue, and I also have a lot of interest in technology and software. So they recruited me, and I became the clinical director of the program, and I helped the students bring clinical relevancy to their projects and so forth. So that the state law got changed, and the Eye Center formalized. We worked on a lot of different projects. And then a little over a year ago, we were awarded a grant by the SIVA Foundation to build a mobile vision clinic, which would be a travel trailer which could be pulled to communities and provide vision evaluations. And our mandate in that grant is to serve Native American communities. And we intend to get this mobile vision clinic developed and built. We were planning to have the designs done by now, but with all the COVID-19 issues, we've been delayed on that. And we still hope to finish our designs and maybe begin construction of this mobile vision clinic this May. So that's one of the projects.
One of them.
Now, there's really 4 different pillars, you could say, that support what we're trying to do with the Eye Center. And this mobile vision clinic is just one of them.
Just one.
Okay. Another one is the visual screening. So what's really important is to identify kids that are struggling with these near vision dysfunctions.
Precisely.
Right, and while we've got this mandated near vision screening in all the public schools, the Board of Health determined that the criteria for referral of near vision was a near visual acuity test,
Okay.
whether or not you can see the sharp detail letters up close. Well, many kids with near functional issues, dysfunctions, can pass that test with flying colors. They don't have any
Right.
problem reading small print. So that screening test is not going to identify the kids that really have vision issues.
Right.
So we need a more sophisticated screening tools to find those children that have these near functional issues.
Before we
So,
go further,
yeah.
let's talk about the screening. It's
Yeah.
identifying shapes, letters, words, right?
Uh-huh.
But not necessarily movement in some cases with these screenings, like tracking words and other things, right?
Right.
There's just some things that aren't in that screening that's in the public schools.
Yes. So that's what one of the second pillar, we've got the mobile vision clinic. We've developed an app, a software app
Right.
called the Quick Check app,
Right.
which is meant to function on just a mobile phone.
Cool.
And it is meant to screen both the mandated distance and near visual acuity,
Right.
okay, but also probe for functional vision issues.
Yeah.
Okay, so the child puts on a pair of glasses and they can see a 3D image float off of the screen
Right.
if their two eyes are working together as a team.
Right.
If they're not, they might not see the 3D float.
Right.
That could indicate one category
Yes.
of near vision dysfunction, not all.
Not
Okay. The other part of our Quick Check app is a convergence insufficiency symptom survey. So convergence insufficiency is a medical problem which is well researched and recognized as impacting children's learning,
Yeah.
development, even adults and so forth. And 5 to 17% of the population struggle with this convergence
5 to
insufficiency.
17.
5 to 17.
That's a big number.
That is. So there's a lot of kids out there that are struggling unnecessarily due to these binocular instabilities in their visual system. Okay, so the Quick Check app will perform the convergence insufficiency symptom survey, which is a group of 15 questions that probe for the most common symptoms that children will have.
Yeah.
This is really the way you screen for this kind of a condition, because you can't really measure whether there's a binocular instability in a moment of time.
Right.
These problems emerge when a child has to encounter sustained near activities for long periods of time.
That's right.
So many kids with these kind of problems could pass a screening test that only takes a few seconds.
Or moments. Yeah.
Or moments.
Yeah, yeah, yeah.
It's really what happens to their eyes over time when they have to focus
Yeah.
and converge their eyes on a near activity for a long period of time.
Yeah.
So you really have to probe the symptoms, okay, that the child is having.
Right.
So this Quick Check app will ask the child those questions.
Yes.
All right. So this software will help school nurses, pediatricians,
Yes.
the public, any group that would like to provide a vision screening. They can have access to this, they can learn how to use it, and probe for some of these issues that might be present.
Yeah.
Okay, so that's that pillar number 2. Okay,
2 more.
so first we screen, then we can set up an evaluation.
Okay.
And the mobile vision clinic will solve some problem, but the mobile clinic can't go everywhere.
Yeah.
And when 5 to 17% of the population are having struggles, there's certainly a greater need than a vision clinic,
A mobile
vision clinic can serve. So we really want this mobile vision clinic to be a tool to research and educate effective ways of doing an evaluation and identifying the kids that can that need regular eye correction, eyeglasses, and so forth, that might have eye health issues. These are the regular optometry issues, but that may also then have these functional vision issues.
Right.
Okay, so great. Now you've got screening, you've got mobile clinic. What do you do next? What happens if you find a kid with a problem?
Right.
So you need another pillar,
Okay.
and this is the treatment.
Treatment.
Okay. Now the treatment pillar is split into two,
Okay.
because the eye center is about software and technology. So the eye center has developed a system called Eye Toolbox. Okay. Eye Toolbox. Think of your toolbox that you have at home, full of all sorts of wrenches, hammers, screwdrivers, all the things that you need to fix. Okay. The Eye Toolbox, in a sense, is a toolbox of software applications and a system for these to be then delivered to a patient that may need to access some of those for the purpose of treatment. Okay. So it includes an electronic health record aspect to it, and it also includes a way of connecting remotely with a patient.
Okay.
Traditional vision therapy as being an in-clinic, in-office mode, where, like here I have my vision therapy practice, is great. There's lots of things that we can do and so forth, but there's really going to be a problem of access to these kinds of clinics if that's the only option in town, because many times it's hundreds of miles away.
Right.
So with this COVID-19, and even before then, we were thinking about remote possibilities, and even more so, I think our whole mental way of thinking about telemedicine is changing. People are much more open to that. So we've really been developing a lot of remote access programs for treating some of these basic binocular instabilities. So this Eye Toolbox is another pillar. And the fourth pillar is what we call a map, a treatment map, a best practice approach for treating binocular instability. There's a lot more functional vision issues. There's lazy eyes, there's strabismus, there's problems keeping your body organized and oriented towards vision tasks. There's a lot of different functional issues. We can't necessarily address all of them. Okay? So we need to focus on one, and this binocular instability is well researched. 5 to 17% of the population. This is the one where we want to address today. So this map, if you think of a metaphor, if you have a map, you use a map to get to a destination. You start at point A, you get to point destination B, right? And along the way, you might have little benchmarks, right? And if you take your journey, you might come to a flooded river, so you gotta deviate around it. You look at your map, right? So a map is meant to be a basic journey to get towards a treatment of something like binocular instability. And we have all of our apps and all of our activities organized as little benchmarks. Let's accomplish this, let's do this, let's do that, check, check, check. We're making progress towards our goal. But every child is an individual. So you have to be able to modify the path for the individual need. Okay? So a map is a good starting spot. It helps guide the journey for each individual child and allows for that adjustment along the way. So these four pillars, the screening, the evaluation, the Eye Toolbox, and then the map, which is delivered through the toolbox, is our kind of our emphasis right now. Where are we? We're in terms of the Eye Center is we are formalizing our charter for our Eye Center. And we are building our mobile vision clinic.
Mm-hmm.
We are making progress on these other software applications.
Yeah.
And in many ways, we're ready for finding individuals and groups who want to give these systems a try.
Right.
Because it's when we apply them to real life situations that we learn what is working
Right.
and what needs to be reworked.
Right.
And this is how we make it better and better. And we hope that this system, year after year, can cycle through with a period of screening kids, doing evaluations, finding the issues and treating them, learning from that, regenerating to improve things, and the cycle repeats. We call this a research activity system.
Research activity.
Yeah, and it cycles around, and this is how we contribute to knowledge and understanding of these issues, and make better products that can get out there to other clinics and so forth.
So the Eye Center is on the forefront of developing these tools. You talked a little bit about glasses technology, 3D technology. So tell me just a little more insight of the kind of convergence of medical and technology. Do you have like folks coming in from the technology standpoint, developing these things with medical professionals?
Well, the Eye Center will be collaborating with companies. We're not probably going to develop all of our software for marketing through the Eye Center. We will bring up ideas, test ideas, develop prototypes, and so forth. But it really takes a collaboration with industry leaders to take some of those tools and develop them production ready for the world, so to speak. So we really aim for collaborating with industry that serves optometry or eye doctors across the world.
That's great stuff.
Yeah.
And let's talk a little bit about early detection. Like we have this great route of getting access to services and treatment and research for best practices, but what, in your experience, have you seen are consequences of not catching something early and somebody later? What kind of things have you seen like that?
Well, one of the challenges is that a lot of the issues that school screenings attempt to identify are issues that should have been identified much early in life. The birth to 5-year range is where you can address a lot of vision issues effectively, and then it becomes much more difficult if you identify the issue much later in grade school. So, for example, amblyopia. Amblyopia is sometimes known as lazy eye, and amblyopia is a condition where you can't see sharp and clear in one of your eyes, even though you have the best lens in front of that eye. So there's some reason why that eye can't see clearly, but it's not optical. It's not that that eye just needs a pair of glasses. Okay. Usually it's because the brain has not developed the ability to see sharp and clear through that eye, because one eye has become dominant. Okay, think of it like a train track. Okay, train track has 2 rails. You have your right eye, your left eye. Okay, your right eye rail, your left eye rail. But you also have ties that are holding those rails together. Okay, and they're nice and straight. Okay, now development is a process whereby we lay out the train track of vision, binocular vision development. Okay, so the path is cleared. Our brain is ready to learn, just like we're ready to learn to talk, we're ready to learn to walk, but we don't know how to do that when we're born. Okay, you have to have experiences in life to develop the binocular vision, just like you need experiences in learning how to walk and talk.
Walk and talk. Yeah.
All right. If there is some blockage in that development early on in a child's life,
Yeah.
okay, then what will happen is that brain of the young child, which is very adaptable, ready to learn and do things, it's going to that brain is going to find an alternative pathway. It's kind of like, let's build a one-eye track over here.
It's worked this far.
Yeah. So we got to the block. We can't go any further. Okay, we're going to build a one-rail track over here. Okay. Well, that one-rail track then deviates off from the binocular track, and you're starting to lay into your neurology in the brain this monocular, one-eyed way of viewing things, and you can develop well ahead, you could say, of where the binocular vision got. So then you have the one eye that's delayed way back here, and one eye that's developed. So the rails are not equal. Okay. So oftentimes what happens is the doctors will patch an eye. Let's patch this eye to force this one to catch up. Okay? That's one way of treating it. And sometimes you can get those two eyes relatively equal. But what that eye patch hasn't done is hasn't done anything to help the ties that hold the rails together.
In this case, it would be two separate eyes of equal capacity, but not in tandem.
Yes. Right. So there's more to this amblyopia than just catching up one eye so it can see as sharp and clear as the other. There's a lot more functional aspects that are delayed in that eye that has been delayed, and the whole binocular vision hasn't developed.
Right.
So if you're really going to treat the binocular problem, you've got to not only balance the two eyes, but help with the binocular coordination.
Yeah.
Okay, so that you can continue down that binocular vision pathway. Okay. Yeah. One of the other things that sometimes gets missed is, even if we can get a child back on track binocularly, if they went way down this path with one-eye viewing, it's in their neurology. They've learned how to do it.
Right.
So sometimes they switch back and forth between binocular and monocular ways because it's already in their pattern. It's a way they adapt, and so they switch on whatever mode seems to work best. Ideally, we want that binocular path to be the dominant one. We want that pathway to be pruned and the rail to be shiny, right? We want this other one to be rusted and overgrown and not used very much, right? Yeah. So that's an example of, amblyopia and eye turns, which should be caught very early on, because if you let that development go too far down, it's much harder to go back and rebuild the developmental pathway, because that adaptation has been set into their neurology pretty dominantly. And you have to bring them back to where their development kind of ceased to happen binocularly, and then start building it from there. So the map, so to speak, is much longer journey when you get older and so forth. It's not impossible. You can take care of amblyopia at any age. The map is a bigger journey. It takes more motivation and so forth. That's why it's so important to take care of these issues earlier, which means identifying and screening through pediatric child visits, not school screenings.
Not school screenings.
Don't wait till school. So pediatricians need to have the tools to screen for these issues, and maybe that's another area that the eye center can work with.